Welcome to the NEI podcast. This is Dr. Sabrina Siegel, and I have here with me our guest, Dr. Rona Hu, and we are discussing National Minority Mental Health Awareness Month.
We sometimes prefer to use the term culturally informed instead of culturally competent, because it's more of an ongoing process rather than a destination that we sort of reach.
I love that. Great.
Because then people don't feel bad if they need more information. We don't want to imply that somebody's culturally incompetent.
You're right.
I might feel pretty well informed in working with one group, and then I'll meet a patient from a group that I haven't worked with much before, and there'll be things that are surprising and new to me. But that doesn't mean I'm incompetent. That just means that I need more information in that area. So we'll use the term culturally informed.
I know we talked about just minorities not having adequate or as rate of access to adequate mental health care. But what about some of these other statistics, like that minorities are less likely to use community mental health services, they're more likely to use emergency department services, and happen to be more likely to receive a lower quality of care? Why do you think such statistics occur, and how can we try to overcome these?
It's a pretty big question, but I think stigma is part of it, and this idea that if they even seek help, that this will be a source of shame. Um, Jeff Lieberman tells a very good story in his book. I can't remember the full title, but the first word is shrink. Like a history of psychiatry, and a Korean American family where even when they found out that help was available, they were too ashamed to ask for it. So in most immigrant communities, people don't necessarily know that help is available, but even then, even the information about the help, sometimes they're still ashamed to get it. Um, and then cost and insurance and so forth, that can always be a big source of disparity. A lot of times, if there's a carve out for mental health, they don't want to feel like they're going to have to get it, and so they will, choose a plan that doesn't have as good of a mental health plan. So there's a lot of education to be done about mental health being not a moral issue, but an illness that's treatable, and that there's effective treatments, and then things that lower the likelihood of stigma. So having referrals from a primary care doctor, um, having waiting areas where the patient is able to say which doctor that they've come to see without it being immediately obvious what the issue is. Um, having translators that are well trained. Um, if the patient speaks another language and we're having a family member doing all of the interpreting, then they're likely to leave things out, or well, the person who's doing the translating can leave things out, but also the patient can leave things out. So it's like, oh, I don't want my son to know that I had these sexual issues, for example. I don't want my husband to know um, that I, was with someone else before I met him. Things like that. There's going to be any number of things that can't be communicated when family members are there. So use interpreters whenever possible, and then um, and then there's a whole set of skills of how to talk with interpreters, and how to work with interpreters the best. And then, if possible, having an interpreter from that patient's group, but who isn't directly known to them, because if they feel like their mental health issues will be broadcast to the rest of the community, they're not going to be very open. I have a specific tip for clinicians in terms of asking family history, which often the patient will say no. And when that happens, I don't let that stop me. I try to get as many family members as possible and I make eye contact with everyone. I'm watching everyone in the eye contact they have with each other. So in this case, I tell the clinicians to, put down their notepad, look away from the computer screen, be watching when they ask, and not just say, is there any
Mhm.
family history of, whatever, family history of depression, family history of schizophrenia. So rather than ask just, is there a family history of depression? You can ask about some of the behaviors that go with depression, or schizophrenia. A lot of times, if you just ask family history of schizophrenia, the family will automatically say no. Um, so if you say behaviors, and then kind of give a graceful way of not losing face. So, was there a family member that had to live with other adult family members, never got married, uh, didn't have a job, mostly kept to themselves? That's a very high yield question that can look for, cases of very severe depression or schizophrenia or bipolar. If you're asking about bipolar, rather than asking, has anyone else in the family had bipolar, ask about, well, gosh, did was there someone who wasn't responsible with money? Was there someone in the family who gambled? Someone in the family who was very smart but had trouble keeping a job? That sort of thing. That's often more likely. And then looking for if as you give these examples, two or more of the family members kind of look at each other, this very kind of quick eye flick, then you can ask, what was that? When I asked about irresponsible with money, you looked at each other and sort of, pressing them a little bit on that. And so there's often a family member where they'll be sort of like, well, that wasn't his fault, or, he's really fine. He's smarter than most people, and people don't understand him. It's like, okay, that's fine. You know, how old when that started happening,
Right.
and to ask that way. And particularly asking questions about suicide, um, that's obviously considered a sin in many religions and considered a shame by family members. And definitely in some cultures, people will consider other members of the family to be less marriageable, or even cursed if there's been a suicide in the family. So when you ask if there's a suicide in the family, the answer might be no, but then you can ask, well, have there been any unexplained deaths? Have there been any drownings? Have there been firearms accidents, poisonings? Um, and so in some parts of China, it's insecticide poisoning. In Japan or many coastal areas, it'll be a drowning. In rural Japan, sometimes it's someone who's thrown themselves on the subway tracks. So these are things that you can ask about, and again, sort of look for the eye flick, this kind of knowing look between two people,
Right.
non-verbally, even as they're saying no. So one real example that I've used is when I asked a Chinese family whether there was any family history, and they all said no. And I had, multiple family members in there. And then when I asked about any drownings, there was this eye flick. And then, the older members of the family said, no, no, nothing. And then a younger family member said, well, grandma fell in the well. And I remember thinking, well, the well doesn't move around. So it's not like grandma went to, feed the livestock and she fell in the well. But, I asked, well, gosh, what happened right before grandma fell in the well? And they said, well, grandpa got a concubine. And, so this was, decades ago. This was many years ago, and they were very ashamed, but they didn't want it to pass down in family lore as being a suicide. So they treated it as an
Right.
accidental death. And you might have to find out from a particular culture which are the ones to ask for, because it's going to be different, and it's going to be different in rural versus urban areas. In some parts of India with women, they're called cooking accidents. Um, and in some groups there will be access to firearms, in some group not. But I mentioned insecticide poisonings in China, in rural China. Um, that's not something that most American clinicians are familiar with, so they might not know to ask for that. So,
Yeah.
working with your patient and the patient's family to find out more about the culture, for things that you might be missing.
Right, absolutely. Asian American adults were less likely to use mental health services than any other racial ethnic groups. What are the reasons that you can think of that this might be the case? And I know I kind of wanted to ask you if you could share a little bit about your experience with these vignettes that you've been doing, because I think that that may touch on that. I remember that there were some um, cultural attitudes and challenges that were presented in those vignettes when it came to mental health stigma and just whether or not, in particular, maybe adolescents would shy away from using mental health services and things like that. Is there anything that you'd like to speak to about that?
Yeah, thank you for the opportunity to talk about this. We're opening up an Asian-specific mental health care clinic here at Stanford in psychiatry. So we will be looking at East Asian and South Asian patients um, who haven't been going to get psychiatric care for all of these reasons. So we want to have a something that's easy for them to get to, something where they feel like they're being understood. There'll be language competencies, interpreters for major languages. I speak Mandarin, but we'll also have people who speak Korean, Vietnamese, Cantonese, and then more and more, South Asian languages as well. Um, so we hope to address some of that. And then on a more preventive end of things, we've been doing little miniature theater pieces for parents of Asian teenagers, because this is an area where Asian teens are actually at a higher risk of suicide than their non Asian counterparts in the United States. And part of this can be the mismatch in communication between parents who are born in another country and the kids whose friends, whose media, whose everything around them is Americanized, and they're not understanding each other, not just because of language difficulties, but because of cultural assumptions. So we have these kind of fun, humorous, but also touching vignettes where we first perform a particular little play one way. Version 1.0 is the way it really happened, and then version 2.0 is a way that we suggest it might go better. So, for example, a very simple vignette would be a bad grade, or saying you should have studied, and the teen interprets it one way, where the parent meant it another way, and saying you should have studied, which they can't do anything about now, right before the test, kind of shuts off communication and makes the kid less likely to want to confide in the parent in the future. Whereas if they say, oh wow, I'm sorry, have something good for breakfast, or you know, um, be sure to tell me about it after you get back from school. I hope it's not as bad as you think, but so something like that. The timing of how they communicate. We have a skit called "What's Wrong with You," where in real life the parent asked the teen, what's wrong with you, in this sort of accusatory way. And we show in version 2.0 that if the parent says, hey, what's wrong, sweetie? I notice you're not feeling so well, that's a lot more empathetic than what's wrong with you. The same teenager reported that when she said, when her mom said, I need to know if you're doing something stupid. That was something she couldn't answer. She said, there's no good answer for that. Whereas if the mom says, I'm worried because it seems like you're, um, it seems like you're doing things that aren't good for you, and that worries me. So the parent communicating that she's worried rather than angry, that goes a long way. We have a skit called Unsuitable Boy. And we have all these on YouTube. We go to schools and we perform them live, but we also have them on YouTube. So, Unsuitable Boy is about a, a young Asian woman who brings home a boy who's not Asian. And her part of this is based on my own life. And, if the parent says, I forbid you to see that boy, that's probably not going to go well. It's not going to accomplish what the parent wants nor what the kid wants. But if the parent is able to say honestly, I'm worried with whether this boy likes you for you or if he just thinks you're exotic. I worry that he doesn't really understand what you're like. That's that's I think a conversation where you're both on the same side of things rather than opposite sides. So if the mom says, I don't want you to get your heart broken, that's different
Right.
than I forbid you to see that.
Well, I will post some information down below in terms of where people can find these vignettes on YouTube with their permission. Um,
Yeah, it's www.stanfordchipow.com, and Stanford Chipow is spelled STANFORDCHIPAO. Stanford, obviously, like the university. And then there's no dot between that and Chipow, which is communication health interactives for parents of adolescents and others.
Great. Well, thank you so much, Dr. Hu, and I really enjoyed speaking with you today, chatting with you, and we look forward to having you on our show again. Thank you.
I enjoyed speaking with you. Thank you so much.